many of the things have been discussed in the last talk itself. So what I am going to discuss, so it is predominantly on the ER positive and the HER2 new and predominantly the HER2 low breast cancer, which we have been discussing over the last half an hour. Next slide. We know that these are the classical three subsets. So since 2 decades, we are treating the cancers in the concept of either they are ER positive or HER2 new positive, which are 3+ or 2+ fish positive, and the triple negative. And with the availability of the ADCs, especially the trastuzumab deruxtecan, the spectrum has widened, and we now have a concept called HER2 low, which are 1+ and 2+, for which the according to the previous talk we had seen, the trastuzumab deruxtecan has changed significantly. So because of the short of time, we'll discuss the key concepts, what we do in our routine practice, and we'll try to wind up as soon as possible. The next slide. So coming to the ER positive MBC, Dr. Mukesh Ulania. So a key takeaway. So do you differently manage a ER positive subset in the first line with bone-only metastasis, with visceral disease, or with visceral crisis? 3 subsets we will have. So how do you typically manage in your routine practice?
So if patient have only bone only meds, then we start CDK4/6 with endocrine therapy. And if patient is severe visceral crisis, like increasing OTPT or lung due to patient is symptomatic due to lung metastasis, then we start with chemotherapy.
Okay. Next slide. So, Dr. Mukesh Chowdary, what is your second line of treatment and your experience of alpelisib?
Yeah, if a patient progresses on first line CDK4 with endocrine therapy, and we tested for PIK3CA mutation and found positive in the liquid biopsy or on tissue, and then we start with alpelisib with second line fulvestrant. And patients are doing well. Many patients receiving alpelisib with fulvestrant.
Dr. Mukesh Chowdary, are you there?
I think Dr. Mukesh is not there. Dr. Lalit and Dr. Sudhir is there.
Sudhir. Yeah, thank you. Dr. Sudhir, so what are your thoughts? So any experience of using alpelisib? And I had few patients, so but they are not tolerable and I stopped in between them. So quite a problematic drug to use in routine practice, according to me.
Yeah, but in the PIK3 way positive is there, then we can try for the alpelisib with the fulvestrant only.
Yeah. Next slide. So majority of the times I use only fulvestrant alone because so a lot of tolerance issues with a drug like alpelisib. So
Yes,
first line, my practice is AI with CDK4/6 inhibitor, and second line, I will try to start alpelisib, but majority of the times I'll land up in giving only fulvestrant as a single agent. Then in the later lines of therapy, the concept of HER2 low has came. Next slide. And this has already been discussed, the HER2 new, the HER2 low concept and the HER2 ultra low concept and the HER2 negative, which was discussed in detail in the last slide, previous talk. Next slide. This is the distribution of HER2 negative. So Dr. Sudhir, what is your routine? Previously, we used to do only ER positive disease and HER2 positive disease and triple negative disease. So now with the concept of this HER2 low concept, so how many patients do you see as a HER2 low disease in your routine practice? If you see 100 breast cancer patients, you take metastatic, non-metastatic, how many will be on an average HER2 low?
Sir, HER2 low mainly in the triple negative disease is there. Then the HER2 positive is there, and then hormone receptor positive is there. If the TNBC, then around 1/3 patient or positive for the HER2 low.
So, Dr. Lalit?
Yes, I would
Dr.
consider amongst if all patients considered altogether around say 40 to 50%. But if in hormone positive, the number might be slightly higher, say 50-55%. We haven't compiled the data, but that is the general kind of idea.
Yes, sir. This is the depicted the publication according to the HER2 low. So a slightly higher percentage in the hormone positive than in the TNBC subsets, and around 30 to 40% can be HER2 low in our routine day-to-day practice. Next slide. So coming to the trastuzumab deruxtecan, extensively discussed that this is one of the most potent antibody drug conjugate which was developed to treat the HER2 new positive disease initially, later moved on to the HER2 low subset disease also. Next slide. This is the Destiny 4. It was discussed in detail. I'm not going to the trial proper. Next slide. This is next slide. So, Dr. Sudhir, are you okay with the trial design and the outcomes of the Destiny? So, what's your key takeaways from your personal opinion on the Destiny 4 trial?
Yes, sir. There is a data for the patient with the HER2 low is very promising with the PFS also and trial design also, but there are the less clarity about the hormone positive patients are there.
Dr. Mukesh Rulania, your opinion on the trial design and all other aspects of the clinical trial. You are very convinced with the data or any flaws you find in the trial?
No, the data is very strong because the patient already received at least 1 to 2 lines of therapy, and the patient have limited option in this HER2 low positive metastatic breast cancers. So trial design, I think this is okay with coming to because this is trial later line setting. So I'm comfortable with this design.
Okay. Next slide. So these are the few facts. So according to the trial, so 21% are initially screen failure, and there is no platinum in the control arm, which we routinely use in cases of TNBCs or in the later lines of ER positive disease. And the trial is not a 1:1 randomized trial, and it is a 2:1 randomized trial, and that is okay in later lines of therapy. We do accept because majority of the trials are designed in such a way. Next slide. But the only problem is, so majority of the patients in the post-progression in the treatment of physician's choice has not received the TDXT. Only a very limited number of patients has received. So that may not be an ideal thing in a well-designed randomized trial. Next slide. So these are the overall survival results in the hormone positive, as previously discussed, a significant survival benefit in terms of both progression-free survival and overall survival. Next slide. And this is in the triple negative, that is the hormone receptor negative subset. So, but the population is only very little in the trial, the hormone negative population. Next slide. But there was a significant benefit in those population also. This, according to the subgroup, so all the patients has significantly benefited in terms of the OS. Next slide. Next slide. So these are the key takeaways from the trial. So post-progression therapy details are not there in detail, and there is no difference in either 1+ or 2+. So the drug has worked equally in 1+ and 2+. And for post 2 cycles of chemotherapy and age above, the confidence intervals are above 1. And as I previously told, the hormone receptor negative patients are only very smaller subset, represents only 58 patients, and majority of the patients included in the trial are the hormone receptor positive patients. Next slide. So practical aspects, Dr. Lalit sir. So do we do routinely biopsy at every progression, and you are classifying all your patients as HER2 low and HER2 ultra low at progression?
Because ideally, we would love to go ahead with biopsy at progression, but in a practical world scenario, I believe not more than 60 to 70% are be able to kind of biopsy at progression. We would like to reclassify our patients at progression regarding HER2 also, and probably go ahead a lot as per the reclassification at the time of progression.
Dr. Mukesh Rulania, so your pathologist is confident in distinguishing the HER2 positive disease 0 and ultra low, because across trials we had seen that there are inter-observer variabilities in reporting the HER2 new positivity. So does your pathologist know the concept of HER2 low, ultra low, and HER2 0, and the availability of new drugs and the clinical impact of reporting of these HER2 low concept?
Currently, our pathology is reported at HER2 0, 1 or 2 or 3+. They are not separately reported ultra HER2 low and HER2 low disease. Currently, they reported according to initial scoring 0, 1, 2, 3 at our center.
Okay, next slide. So this is HER2 low and ultra low. So already discussed a bit. So because of the time, I'm skipping. Next slide. Next slide. Next slide. So now the question. So for HER2 low and ER negative patients, so we now have two possibilities. Previously, they are called as TNBCs. So we now have two options: TDXD, the trastuzumab deruxtecan, and saxatumab govitecan. So Dr. Mukesh Chowdary, so what do you prefer in these patients? Classically, before reporting of this HER2 low, so these are considered as the TNBC patients, and there is a data of HER2 new positivity reported from the saxatumab govitecan trial also. So if at
Yes,
all
yes.
you come across a patient, so what do you prefer?
So there is no head-to-head comparison between these drugs, both drugs, and we have only available at present trastuzumab deruxtecan. So I would propose trastuzumab deruxtecan. We have no saxatumab govitecan at present.
Dr. Mukesh Chowdary, any thoughts?
I think, sir, Dr. Chaudhary is not here.
Okay, Dr. Sudhir.
Yes, sir. There are the data for this SG also for, but as Mukesh said, there is no head-to-head comparison with the TDX1. But if it is the HER2 low, then we go for the TDX1 also.
Okay, next slide. So this is the data which was presented according to HER2 new IHC status. The saxatumab govitecan also showed positivity in the HER2 1+ and 2+ studies, and typically these two are options. So there is no head-to-head comparison as previously discussed, and we can sequence one by one in this population too. Next slide. So Dr. Lalit sir, so what is your experience of using this? And there is a lot of buzz regarding the development of ILD, and the significant number of patients develop ILD. So what is your clinical experience of using this drug, and the toxicity profile you have seen if you have used this drug?
Well, sir, so far, touch wood, say around 4 or 5 patients are there in whom I've used this drug. And the maximum PFS which I've so far got is 6 months plus. Thankfully, none of them has developed ILD. But to be on the safer side, we are doing HRCT every 3 months and DLCO every 3 months. Thankfully, none of them has developed so far.
Next slide. Next slide. So significant number, so almost 20 to 25% developed, and possibly it is problematic to use in patients who already have a bad lungs, either due to the disease or because of previous coexisting lung comorbidities. Next slide. And this is the real world data, perspectives and practices for pneumonitis and interstitial lung disease with trastuzumab deruxtecan. Next slide. So 15.3%, the pooled analysis of non-studies. So almost 1 out of 6 patients will develop it, and median time to onset was 4.3 months, and 2.2% we have a grade 5 event, that is death due to this interstitial pneumonitis. Next slide. So definition, because of the time, I'm skipping these slides. Next slide. So we all know this drug causes significantly in interstitial pneumonitis, and grade 3 and above will permanently discontinue it, and grade 1 and 2 you can rechallenge. Next slide. So any concept, Dr. Sudhir, do we use
Yes, sir.
TDM1 for HER2 low?
Sir, there is a node in the HER2 low only TDX1 because it is
Because
more
both are antibody
more
drug
potent in the.
conjugates.
Yes, sir.
Both
It
are
is more.
antibody drug conjugates. Yeah.
Yes, sir. It is more potent than the TDM1 in the efficacy in the antibody conjugate. Both are there, but TDX1 is the upper hand to the TDM1 in direct trial is there, and HER2 low only TDX1 is approved according to the data.
Next slide. Yeah, we have some data to say that TDM1 is not as a robust antibody drug conjugate as
Yes, sir.
TDXD, and it shows that TDM1 doesn't work in this HER2 low subset, and we typically don't use TDM1 in HER2 low subset, and TDXD is the only drug we are going to use. Next slide. Next slide. Dr. Mukesh and Dr. Sudhir. So what is your experience of using this TDXD? Next slide.
I have not used till date TDXD.
I also have not used, but sir, there is a 50 mg problem is everywhere. costly
Yeah.
drugs. So maybe round off is better, sir. Like 344,
yeah.
300 is better, sir.
Yeah. Okay, fine. So typically we tend to round off to the lowest possible value and give it to the patients.
Yes, sir.
So to conclude, so TDXD especially is a game changer in breast cancer. We have seen its outcomes in the HER2 new positive disease and especially in the HER2 low disease, and the trials are happening in the adjuvant and also in the neoadjuvant setting of the HER2 new positive breast cancer. Possibly it significantly will change even in the non-metastatic breast cancer, how we treat the HER2 new positive disease after the publication of those results, and significantly it is a very potent antibody drug conjugate and is an ideal choice in later lines of therapy in the HER2 low positive disease. I thank Dr. Mukesh, Dr. Sudhir, and Dr. Lalit for their wonderful comments.
Thank you, sir.
And I thank organizers for this opportunity. Thank you.
So thank you, Stalin sir, and thank you all my panelists for this wonderful panel discussion.